Shelley, are you there? Shelley, are you there? Julia, are you there? Hello? Shelley, are you there? Are you in the conference room?
This is Carlos with Campus Park Fund.
So I just said it was for everything.
Julia, can you hear me? Yeah, tell Shelley I'm on the phone. Nobody's answering me. Maybe they have me on mute. But I can hear everyone.
We have a big agenda today, so we are going to go ahead and try to get started.
I've been in the back. I've been thrown out of better places.
You can take my chair, Dan.
Where are you going?
Going to go ahead and call to order. Shelley, can we do a roll call, please?
Alberto Goodyear, Bob Ramsey,
Here.
Brian Smith,
Here.
Chris Salvino,
Here on the phone.
Dale Woolbridge,
Here on the phone.
Here. Oh, Dale's here.
Deborah Garame, Gail Bradley, Dark Gamer,
Here.
Glenn Kasperzik,
Here.
Heather Miller,
On the phone here.
Howard Reed, James Hayden,
Here.
Jonathan Mayhem,
Present.
Melanie Mitra, Michelle Preston, Mike Duran,
Here.
Mike Garcia, Neil Williamson,
Here.
Rebecca Harrow,
Here.
Brian Page,
Here.
Robert Costello, Rodney Reed,
Here on the phone.
Sarah Parati, and Todd Haramiel,
Present.
and Vivian Gellert.
Excellent. Thank you, everyone, for being here. Attached in the packet is the attendance report. Per council bylaws, just a reminder that if a member misses 2 consecutive meetings, you will get an inquiry from the Bureau as to whether you would still like to participate in this committee. If you have had any change in your contact information, email, phone number, et cetera, please notify Shelley so she can get that updated in our system as well. For a vacancy report, we currently have 5 vacancies. These include non-governmental employer of intermediate EMTs, hospital administrator for population greater than 500,000, volunteer medical rescue program, a representative from a local EMS coordinating system northern region, and representative from a local EMS coordinating system central region. These roles are appointed by the governor and the terms run for 3 years. If you're interested in any of these vacancies, go to submit an application on the governor's website. It's Board of Commissions, and if you just type in the Arizona Governor Board of Commissions, you'll find that. A reminder, we do have to update the bylaws every 3 years. We will start this process at the May meeting with a vote for approval of any recommended changes to the bylaws at the September meeting. The next review report, Terry.
Thank you, Dr. Bradley. In your package, you have a document which is a summary of the current rulemakings that we are involved in. Most of these are related to vehicle licensure, equipment lists for both air and ground, but also included in this list are the certificate of necessity rules and the rules for the administrative or the revenue and cost reporting documents. The next likely meeting, I haven't confirmed it today, is a joint meeting to just finalize the air vehicle equipment list and the ground vehicle equipment list, just to take advantage and make them harmonious where we can. And then those will be shelved because they'll be essentially done. A lot of attention is on the certificate of necessity rule writing process. There probably will not be another action on that until sometime in February or early March, when we release the first draft based on the comments we've received from the stakeholder community and from comments we've received over the years and from our 5-year rules review. So, and then after we release that document, it'll be open for comment, and then we will hold the first work group meeting. We anticipate a very large group of individuals participating, and so we're actively looking for a big meeting room. But we will be absolutely transparent. Everybody will have an opportunity to participate, and we will be very transparent to the notification process. But anyway, this document is also available on our website. You can keep track of what the rule writing process says. But if you have any questions, just contact us and we'll let you know.
Thank you very much. Next, Ben for service selection update.
We'll talk about a couple of the projects we've been working on for a pretty long time here. The EMS registry to trauma registry linkage is almost done. We're having a vendor do some acceptance testing to make sure it works the way it's supposed to. And then also to piggyback on Terry's comment about advertising the rules update stuff, I will again plug, if you have not signed up for email updates from the Bureau, please go to the ADH website and sign up for GovDelivery bulletins from us. It's the one of the few really effective ways we have to communicate with our stakeholders. It can be buried because we're under the Health Alert Network, so if you have any problems signing up for it, send me an email and I'm happy to help. But please do sign up for those emails from us, and then my team will present a couple of the other deliverables we've been working on for a long time that you've been hearing me talk about. So I will be quiet now, and we'll talk about those in a little bit.
Thank you very much. Next up, Boston.
So the Governor's Office of Boards and Commissions, so I got several people ask me questions about the membership. I'll kind of reiterate what you all probably have heard before. We don't manage the membership process. That's through the Governor's Office of Boards and Commissions. We have heard that they are going to be actively looking at the membership, so if you have been thinking about putting in your name, or if you have put your name in, just understand that that's probably something that's going to happen in the next month or so, if it's like in previous iterations.
Thank you. Boston, let's have the EMS annual report.
We have developed this EMS annual report. We did one annual report in past few years back, and then we were mainly doing reports on time-sensitive illnesses and not an overall annual report. So this time we decided we will try to do this yearly EMS annual report too now, as we are consistently doing trauma report, and now it's time also that we should do consistently EMS report. This annual report is developed using the 2018 calendar year data, and this report talks about, kind of gives an overall picture of two parts of EMS calls, like 911 and interfacility transport. So the first part is divided into 911 call, and it describes the volume of which time day of the week or which month the volume increases, and county, urban and rural rate of where it is more, and then it talks about the age, gender, and those kind of things. And then the same thing with the interfacility transport, what's going on with those calls, and then those patients who were transported to the hospital, then what we did is we linked those patients with our hospital discharge database with a pretty high linkage rate of 92%. We got a success rate of linking that data to hospital discharge. So now those patients who were transported to the hospitals, then what happened to them at the hospitals, what was their discharge status, what was the mortality rate, how many got admitted, and those kind of information. So it's a pretty higher level information you will see. The report does not goes into detail of some of the detail of particular illness or those kind of things. That's not the place where the annual report is. Otherwise, because EMS is so vast, this will become a huge report. So we decided that our specific reports we will concentrate in our quarterly reports where we'll talk about a specific illness, but this report will concentrate in general about EMS 911 calls and what is happening with that. So as you see over here, EMS. Using 2018 data, we have around 900,000 EMS incidents were reported. And we did some kind of exclusion like standby calls, false calls, cancel, the two things like those people who were dead at scene, 3,568 people died on scene. We removed those from the analysis, not because the mortality is not important, but because if the patient is dead, then we do not have any kind of further information.
Home to Tempe Town Lake, Mill Avenue, and Arizona.
Oh, okay. I thought it's a question too.
We'll track you down if you're calling from Tempe. Just a reminder, if you're on the phone, please hit mute and not hold. Are we able to figure out that we can silence them, or? Thank you. Excellent.
Yeah. Because there is not much information available to do further analysis, we removed it at that stage. And after removing those patients, then we divided into 911 response, how many were interfacility transports, and then there is some other kind of calls. So that's again the same picture over here. You will see the majority of the calls are 911 response on scene, like 80% of them, and interfacility is around 5.7% were interfacility transports, and then there is a medical transport and others. Now this figure talks about the distribution of 911 EMS incidents by month. We had around 678,000 some cases of 911 EMS calls for the year of 2018, and you see that the spike and the average volume is around 50,000, and more so in the month of March, from around 60,000. Then which day of the week, and we can see that the Monday and Friday, those are the two busy days compared to other days. Then 911 EMS incident. This is what happened to the patients on scene, what was their disposition, how many were treated and transported, transferred, no treatment required, how many refused treatment, and those kind of information is here. I think let's go to the age. There are two graphs on age. Figure 1 is showing us the percent of incidents as compared to the percent of population in the state of Arizona. So that is how we interpret is, well, let's say take 1 to 4 year old. So our 5% of Arizona population is less than 4 year old, where the number of EMS incidents happening in that age group is 1% of EMS call volume basically is in that age group. So you can compare the population and EMS call volume. So as we see that as the age increases, the population proportion decreases, but the call volume, that incident proportion is increasing in that age group. So elderly people are overly using EMS calls as proportionate to their population in the state of Arizona. And when we look at the incident rate per 100,000 by age, we also see the same pattern that as age increases, the EMS 911 call volume increases with 85 and highest rate. Then there's a gender. We didn't find much difference between the gender between male and female. Then 911 EMS incidents by county. What we saw that, we still have more rural counties volume increase compared to some of the urban counties. Now, obviously, Maricopa County, we see such a small volume, but we do not have all the representation from all the EMS agencies for Maricopa County. So that is one of the reasons we see lower volume. And when we look at the below graph where it is urban and rural, now this takes into account the population of, so it's a rate. So basically it's a population, takes into account the population of each of the counties in rural and urban, and we see the urban is lower compared to the rural. Rural is higher for EMS incident rate per 100,000. That graph also takes into account the population, but this is each of the county, and this kind of tells us that, yeah, most of the same thing, but it's like most of them in the rural county. Gives you a clear picture over here. The 911 EMS incidents treated and transported. Now this section talks about those patients who were treated and transported to the hospital, which is around 400,000 from what we saw the number before 900,000 some EMS incidents. Now 400,000 EMS incidents, they were like treated and transported to the hospital, and then we connect them, link them to the hospital discharge database in order to find it out, okay, what is happening at the hospital. And what we found out that 62% of those patients were discharged from ED, and 30% got admitted to the hospital. And then we can see how many went to hospitals or, rehab and mortality and all the stuff over here, which comes from the hospital discharge database. And these is our interfacility transports, and we knew again from the first page that around 48,000 were interfacility transports. And then, yes.
Can I ask a question about the previous chart? I think it'll be interesting to follow this one over time. I was surprised at the percentage of patients who were admitted. It seems higher than when I used to be in the business. So I just wonder if we transport more acute patients here in Arizona than, perhaps it's a result of the treat, refer, or alternative transports or something. Maybe we can track this one over time.
Okay.
I'm guessing some of that has to do with the aging demographic as well.
Could be the reason they require more admissions than other, right? Okay, can we go to the next page? Interfacility transports by month. And again, I think that might prove your theory, Dr. Bradley. It's like, after June we see that the interfacility transport increases, now the winter birth starts coming in, and then we might see that, yeah. Age. Interfacility transports by county. Let's go to the next page. By county. By county. Yeah, so again, over here also we are seeing the same picture. Let's discuss. As our interfacility transports are happening more among rural. Now, obviously, that's right compared to the urban. And then overall mortality in hospital versus on-scene death. So this is in-hospital death comes from, again, from the linked database with the hospital discharge. We get the mortality. So around 10,000 mortality patients died in hospitals, whereas 3,568 patients died on scene.
Russell?
Yes.
How well is the linkage going on this overall so that an agency would have the potential to be able to look at, say, condition, presentation, and at least, the big categories of outcome?
Right. So the problem is that hospital discharge database is 6 months behind, right? When I get it, it's already 6 months done. We are pretty much up to date with the linking, and the linking is awesome. Like we get 92-93% success rate in linking. So everything is on our side is perfect. It's only part which we cannot control is that when by the time we get hospital discharge arrival, it is already 6 months late.
So real-time
Right.
QI wouldn't work for this, but given the lag, do you think it's getting pretty good? So for instance, if over time, would an agency be able to look at, say, overall cardiovascular mortality trends, et cetera?
Yeah,
And there's a lot obviously packed into that, but it's way more than what we've had, which is, we've never had that kind of
Right, and
information.
we can.
So, sorry, I'll brag a little bit on Bustle's behalf, so for the.
I've done that a lot.
Yeah, so the HDD linkage for these reports, so we're actually finally in print, published in Hospital Emergency Care for this linkage, so our linkage rate is extremely high quality, 16 linkage steps. And because we're at the Department of Health, we have the PHI for both the hospital discharge and this one, we're very confident it linked well. So if we're using a report where we don't need real-time or close to real-time data, and the 6-month lag is okay, we're confident that the outcome data is excellent. We have been talking about our HIE linkage program. Right now, we have 6 agencies enrolled with a link from their AZ peers to the HIE, and they can get outcome data back usually within an hour.
Right.
It's the discharge diagnosis code, and then the primary, is it procedure code?
It's sometimes procedure code if the hospital sends it back, admit, discharge information, and sometimes disposition to home, skilled nursing facility, things like that.
So so right now with the 6 agencies enrolled, there's the potential to create that sort of real-time QA. I mean, that's kind of our goal, and how we were able to do this project was, we know that for EMS agencies, being able to do some real-time QA and immediately get an outcome back, especially for a rural agency where someone may be transferred, even multiple times to a tertiary care center, to be able to get that discharge diagnosis back is very important for that. And so that's the piece we're still working on. We're learning kind of as we go with the HIE, what they need, what we're getting back, and hopefully that will only get better as more agencies get enrolled.
Right, so if you are looking for real time, we are working on it. But if you are okay with doing some retrospective studies,
Well, to me, both and is great, because there may be some accuracy issues, even some double checks and so forth that you can do, but I just would like to point out that there's like, for instance, I've been talking with multiple of the really gigantic national, international EMS agencies, and, they're really proud about being able to, present 1,100 crikes because they have, 17 million EMS runs, but the reality is, still almost no one is linking. And only a health department can really pull that off because of HIPAA and confidentiality and all those issues. So thanks for doing this effort. This is an unbelievably gigantic effort. What we saw in writ small with Epic, where thanks to all of you, we linked 36,000 PCRs, right?
Right.
That's just about like 3% of the EMS population. So we just got a little snapshot of how hard it is to do this. So thanks, because most states aren't even raising their hands for this.
Right.
And until we get linked outcomes, everything we always say about all the lives we save are really, it's just TV. It's good for TV, but it's not real.
Yeah, and our methodology paper is already been published in Pre-Hospital Emergency Care.
Did that come
Journal.
out?
That came out, we published
Would you
it.
mind sending that around?
Yeah,
That'd be
and
great.
so we did some kind of internal validity also doing the manual review, and so the linkage methodology is pretty solid. And as you said, when I did the literature review for that paper to find it out, okay, what other states are doing it, I didn't see any of the states doing it at the state level. They have done it at the hospital level, like one hospital and few agencies in that county, and they have linked it, but not at the state level. So, yeah, I mean, we are fortunate that we were able to do that.
I'd like to just underscore what you guys have been doing and what you were saying. But I think also just some advice is that to be able to create that compression of continuity of care and continuity of information so that we can grow a lot better. This lag time is, 6-month lag time is an enormous step.
Yes.
And what I think might be missing is to have understood within your report what those lag times were just recently, and how that happened, because it was, like almost started like a couple of years when it first started, and then they were hopeful for a year, about 2 years ago. But coming down to 6 months is an enormous step, because that way people can plan prospectively and be able to make that thing happen even a lot better. So I think it'd be nice in the report somewhere to talk about some historical points, especially the lag time between these two basic forms. Because you guys, it's marvelous. It's just amazing what you've done.
So back to overall mortality. Yeah, that's the difference between the on-scene death and the hospital death by age group. Now this last page goes into the specific illnesses, and what we did is that we have included all our time-sensitive illnesses, which is identified by us as that we want to work in the Arizona, like cardiac arrest, STEMI, stroke, and opioid. But apart from that, and trauma, and apart from that, we included few more primary impressions which were more prevalent, like obstetrics, psych disorders, seizures, and those kind of a things, to give us an idea, the volume-wise, EMS volume-wise, like what proportion is this important primary impressions represent. So if we see like cardiac arrest is little less than 1% of your EMS call volume is cardiac arrest. Diabetes is almost 2%. Trauma, 16% of your EMS volume call is 16% is trauma injury, and so on. So it gives us an impression almost 3% is psych disorders, and same as seizures. And substance abuse is 5% of EMS call is substance abuse. So this help us basically identify, our heavy areas, where what are we seeing day in and day out. And then in the next table you will see in each of those most frequently happening EMS calls, what is my mortality. And we see that cardiac arrest is the highest, followed by STEMI. Both related to that, and then stroke is 3% mortality. So this just gives us an impression and help us raise questions in our mind. Okay, now I want to dwell into this illness. Let's go and find it out in my county or in my area. How much is the prevalence? Which age group is affected? Where it is affected? What can I do in order to get them either the care faster or to prevent it in terms of injury? Things like that. So this report basically does not dwell into detail of everything, but it is there to raise more questions, so we can do further reports on it.
Marvelous report, Al. I want to really thank you. I just have a couple little bit of questions may or may not be helpful. One is backing up on what Terry said. There may be certain of these reports and screens that you want to be able to show a comparison of what the baseline was, which a baseline might have been last year, whatever it is. So there may either be a percentage or maybe an additional slide you want to be able to show a comparison between this year and next year, because that will, that'd be great. I think that'd be helpful. The other thing, if you go back to screen one, we all kind of assume the terms, and we know the terms that are being utilized. But what I've found over the years is that a lot of people define things differently from where they're coming from. So it might be helpful to, like for instance, I saw, which was glaring to me, I think, was convalescent or whatever it was. And I thought that was very interesting, because what is the source of that? What is the definition of that? Because obviously that definition is migrating, quite a bit. So it might be helpful to understand that, because then that would explain treat refers and other stuff that happens.
And we have tried to cover those things like that. There is an Appendix A which talks about the definition.
Yeah, okay.
And there is a medical convalescent transport, and then it explains our definition, not our definition, but this is what is a standard definition. Yeah, what working definition is over here. Yeah.
Okay.
It's there.
I think what Bob's trying to say is optics.
Yes.
Our definition of a convalescent transport And the world of EMS, I'm sorry, go ahead.
No, I'm sorry. This one is kind of, I'm chuckling because we struggled with this definition.
Right, we did.
Right? So what is in statute and rule is the word convalescent, so we're trying to define something that's defined in statute and rule, while a practical working definition would be interfacility transport, and then NEMSIS also has the definition, so the way we actually get the data as a third definition. So I'm just chuckling because we spent quite a bit of time trying to think of how to define this one, and I think I left more confused than clear. So this is an area where we would actually very much welcome feedback on what would make it clearer about what we're defining.
Yeah, but what we have used for this report, that has been defined over here in that menu.
When you went through this with Epic, did you have a differentiation in the two different terms with your EMR background data?
It was much easier because current terminology was used both electronically and in analog form on PCRs. And the ASTR, the Arizona State Trauma Registry, is unfortunately the terminology is not driven by statute and regulation. And so it's very functional and it's broadly accepted within the entire trauma system. So the 480 data elements and so forth are all very practical uses. So we didn't have this complication with Epic. And we don't have it with Share either.
Hello, sorry to butt in. This is Howard Reed. I'm present. I just didn't want to interrupt anybody. I've been here for a while.
Thank you. Well, thank you very much to Boston and her team for putting together the EMS annual report. And that is on the Bureau's website. If you go to the main Bureau website, you'll see in the top of the bullet point. What we're trying to do is put up the things that people find most helpful and useful. So things like this report are up there, a quick link to it, as well as the Tableau trauma dashboard, which will lead into what Boston will cover next.
Yeah, thank you. And the EMS annual report, I want to acknowledge actually Vidya. She's my epi, and she did the report. So thank you, Vidya. All right, what are we doing now? Tableau? I'm just giving the overview, right? No.
We can open it and just kind of
Yeah,
go
all
in.
right. So, I know I've presented dashboard to this meeting, but that time it was not available on our website. Now it is live. It is available on our website. Anybody can see it. And so the link is right on our page, on our home page. And if you click on that link, that Tableau opens up, the dashboard opens up. It has introduction, demographic, trauma rate, 400,000, alcohol, drugs, and trauma mortality. These are the 6 basically tabs, and giving you basically, it shows the same thing, exactly what it means. And so that's total number of cases, like 51,000. That's the 2017 year, and gives you what are the top 13 mechanisms of injury, what is the age distribution, and the gender. The cool thing you can do about over here is that if you click a mechanism of injury, then it will change the trend. So if I say, okay, in fall, I want to see what is my age group. Yes, my elderly, the more falls, is that the age group is affected. Male, female, slightly higher female compared to male. So these kind of things, we can do it with the Tableau. It will, each page, if we go, there is some there is either mechanisms or county information available for you to change it, and then it changes the picture and gives you the data based on what you selected. Like this is what is this? This is trauma rate per 100,000, and so which you can tell that it's very high trauma rate in Gila County compared to other counties. Then it gives me over here which race and ethnicity is affected. Trauma rate, American Indian is highest trauma rate compared to white, and what was the intent of the injury, mainly it's unintentional. Now if we select mechanism of injury, maybe we go to firearm. Or no, whatever you want to select. And we can see how the race and ethnicity distribution changed, which county has more, is that a firearm injury? What is it? Yeah, firearm. So which injuries, now the La Paz showed more than the Gila, which Gila was previously, overall Gila was highest, but now we see that, okay, that's more in La Paz County. And the intent of injury, which was unintentional overall. Most of our trauma injuries are unintentional, but obviously firearm is not unintentional. Most of them are not. So those kind of things you can get it through trauma dashboard.
Our hope is to keep updating this with additional years of trauma data. So we started, we got it on the website, we were able to create it, and then we're hoping to add additional historical years with the kind of end plan being we'll just add each year in the fall when we do the stat report, we will add this additional public data to the dashboard so that you'll be able to see this by year.
So pretty soon we will start working on putting 2018 data on this.
And again, big thank you on this. This was a lot of work to put together the Tableau dashboard, but then it took even more work to actually get it functional on the Bureau's website. So sometimes getting two different IT systems to talk together, in case anyone's ever done that, can be challenging. So a big thank you for all the efforts that went into getting this up there. So thank you very much. All right, and last on the Bureau report is the annual staff report. Do I?
Yeah.
So I'm not gonna go into detail of trauma report over here, but just some of the highlights. We have used 2018 data to develop this annual report for 2019 annual report. This data comes from State Trauma Registry, and I think around 49 hospitals reported in the year 2018. So all trauma patients reported by these 49 hospitals are included in this report. So the trauma report, every year we develop this report, and we are pretty much consistent about what the information is provided. It does not change drastically over the years. You will see the same kind of information. Here we try to be consistent. We add some of the graphs here and there. But it gives you a very well-rounded picture of trauma in the state of Arizona. So if you want to talk about, okay, what was the trauma rate over the years, are we increasing, decreasing, what is happening with that, what is the age distribution, gender distribution, race and ethnicity, you will find it over here. Injury severity scores, okay, I want to see which injury severity score, what was is prevalent among which mechanism of injury, or what is happening with the mortality if the severity score increasing. Then you can see what are the different kinds of mechanism of injury, and within that mechanism of injury, what is the mortality. So those kind of things by region, we want to see, like, okay, in this particular region, what is the prevalent mechanism of injury. Traumatic brain injury is one specific area because there are around 30% of traumatic injury, people ended up developing traumatic injury, so we thought we should talk about a little bit on traumatic brain injury. So there's a section on traumatic brain injury, and then there's a section on trauma mortality, and over here, I think trauma mortality, the one thing we did, the one comparison we did is that's our trauma registry trauma mortality, but we compared it with the death registry trauma mortality, because we know that when we talk about trauma mortality, and if I talk from trauma registry, it is always limited because only those patients who are transported to the hospital, who reaches the hospital, they are included in trauma registry. So there are so many trauma patients who die on scene, and then we are not talking about them. So when I'm talking about trauma mortality, that's the only limitation we have using trauma registry, is that I'm not giving you the full picture of trauma mortality. And so that's why we ended up using the death registry to tell us, okay, what is the actual trauma mortality? And you can see how big the gap is between the two. Because we don't talk about trauma deaths happening outside hospital. So things like that is over here, charges, $2 billion some trauma charges in 2018 and consistently increasing over the years. What else is there? Then we do talk about some of the risk factors like drug and alcohol use by age groups, and I think that's drug and alcohol. Yeah, if you see by the drug and alcohol, some age groups more drugs compared to alcohol, and others are more alcohol compared to drugs. Similarly, we see the different patterns of using drugs or the alcohol by ethnicity, and each mechanism of injury basically have more drug and alcohol compared to other mechanism of injury. And then we do talk about the protective device information also, by if it is a motor vehicle occupant, what are cyclists and what is the bike, helmet use, what are bicycles and what is the helmet use. We can see over here in this particular state that we had 1,573 cases of off-road vehicle occupants. But look at the helmet use. It's so low compared to these are motorcyclists and that's our pedal cyclists. So both the way, for pedal cycle and off-road, our helmet use is pretty low. there's a lot of information here. It's a really big report. Yeah, I don't have time to go through each and every, but that's in a nutshell what it is.
Thank you very much.
Thank you.
Next up for Standing Committee of Regional Council reports, Rebecca for TEPI.
Good morning. TEPI met on November 21st. We welcomed 3 new members to the group. Reports that were presented included the motorcycle traffic-related trauma report. We were also given an overview of the Tableau trauma dashboard, which was just demonstrated here this morning. EMS for Children group, the advisory group, still has a couple of vacancies, and Julie can address that. Treat and Refer program application and manual was set then and will be presented today at EMS Council as well for our review and approval. And the Cactus data completion scoring. There was a lot of work done and discussion about this. There was still a little bit more effort that needed to come up with a thoughtful data standard. So close group within the Bureau worked a lot on that, and they have that ready for us today as well at EMS Council. And that'll do it for TEPI. Thank you.
Thank you very much. Next up, Brian for Education.
Morning. We welcome three new members to Education Committee. Dr. Amber Rice, Chris Long, and Matt Shaw are all new members on there. We had 2 agenda items at the meeting. One was to form a work group in conjunction with PACES to put together a training packet for safe sleep. The idea being that when providers are out on scenes, they may be able to identify issues with safe sleep practices by families and friends and so on. And so we're going to look at having training for EMCTs to be able to identify those things, and then how to be able to approach members of the public in order to be able to educate them about safe sleep practices. There was also a recommendation to look at changing the training packets that we currently have for supplemental training, which is in kind of a curriculum format, and switching those out to the PowerPoint presentation format that we've been using for many of the trainings that are posted on the Bureau's website. That has been tabled for now. The National 2019 Scope of Practice Model has been released. We're going to need to be able to look at all of those. That might change what some of the STR situation is in Arizona. And so we're going to be looking at the scope of practice before we decide how to come back and handle how we're going to have the packets available for people to conduct training for STRs. Our next meeting is March 19th right here in 215A at 10:30.
Thank you. And then for PMD, that's again you, Brian.
Okay. We had a presentation. There was a request to add CroFab and Anavip to the interfacility transport list for paramedics. And there was a presentation that was done. This was actually 2 meetings before where this was brought up, and we asked for more information. There was a presentation that was made. A vote ensued after the presentation, and that motion failed to add those to the interfacility transport list. There also was a request to change the format of our drug profiles that we have available, and it's going to look a little bit more like coming out of our T3G model, and that motion was approved to change those profiles over to the newer format. And then the other thing is we just did a big revision on our triage, treatment, and transport guidelines, and we're working on how to plan to continue reviewing those in the future. And Dr. Castro-Marin will be working on with the different people that have been assigned different areas of each one of those, and how we continue to move forward to make sure that people are keeping up with any changes that come out. Our next meeting also will be on March 19th. And that's it.
Thank you. All right, next up for regional EMS council reports. We do have the Ames report that is in the packet. I didn't know if anyone from Ames had anything they wanted to add to the written report. Sadie?
Yes, thank you. Thank you, Dr. Bradley and Chief Mullins and Julia, all of you for attending. We know it was quite a meeting and we appreciate your participation. The pertinent things from our meeting is that we had our chair elections and Dr. Spate got elected again for another 2-year term. So we're grateful for that. And the other pertinent thing is that the council passed our adult stroke protocol. So everything else is contained in our report. Thank you again for coming.
Thank you very much. We do have a names report in the packet as well. Is there any additional verbal report to the written report?
Just a couple of things. At our last meeting, we continued doing a lot of work for our pediatric symposium that will be March 2nd and 3rd at Little America in Flagstaff, Arizona. If you're interested, you can go to the NAMES website and find linkage to registration. The other thing is that I wanted to talk about is some of you may have been around here long enough to remember Giddy Sylvan. She has been kind of our administrative coordinator for NAMES for very, very cheap for many years. And she retired from her treasurer position to hand that off to somebody 2 years ago and to be able to start working with them on the work they need to do as a treasurer. And then she submitted on October 1st her resignation letter as our administrative coordinator. And she has been around for a very, very long time. She started attending Northern Arizona Council of Government meetings, which the county organizations kind of ran EMS in the state for many years. In 1980, she was on EMS Council from about 1981 to 2002. She was with Sedona Fire from 1975 to 1996. And she had the #2 intermediate EMT certificate issued in 1978. And we're going to miss her work that she's done for us. And we have, and I guess in an unfortunate manner, hired our first person who we will be paying to be our administrative coordinator in the future. She's still on our board for a little while longer and will be continuing to help with our pediatric symposium for maybe this year and maybe next year. I think she should just retire and go out and have some more fun than staying with us. So that's all I have to add.
Thank you. And then do we have the last report?
Yeah, hi, this is Rod on the phone. Hopefully you can hear me well. We had our first meeting of 2020 on January 9th in Lake Havasu. It was very well attended. Our next meeting is May 14th, also in Lake Havasu. That will be our annual meeting. We'll be doing elections for the president and secretary. We have completed our provider assistance process for this fiscal year. We had 12 agencies take advantage of that, and we spent like a total of about $52,000 on those requests. January 13th and 14th, earlier this month, we hosted a designated infection control officer class. We had about 50 attendees at that, and it was very, very well received. And that is my report, unless anybody has any questions.
Thank you very much. All right, next up, Dale, I think you're on the phone for PACES report.
I'm actually going to.
Julia, okay.
Yeah, so we had our last meeting as well on November 21st, and so we are almost at capacity for the roster, so thank you everybody who is on the committee. We have one remaining spot, which is open for the Northern Region representative. As was already mentioned, we approved creating a work group for Safe Sleep, so that will be on February 6th. And the other project that we are working on right now is a pediatric emergency care coordinator, which is one of the EMS for Children performance measures. So we'll be kind of finalizing that and how we want to push that out in the future. The last thing is EMS for Children right now is doing national data collection among EMS agencies. So if your EMS agency is getting flooded with emails from me, it's about that survey, and we are hoping that all EMS agencies in the state have the opportunity at least to complete that survey. So that will be on 2 of the performance measures and will be really helpful in kind of directing our efforts in the future.
Julie, when does that survey have to end by?
So the survey ends at the end of March, but I've been sending out emails this month.
So I'll give a separate pitch for those EMS agencies that have been contacted. This is important. This is a requirement for our EMS for Children grant. It happens every 4 years, I think, or so. It's real helpful for us if we get that information. We know you get pinged for a lot of data. We're sorry to do that, but we'll make it as easy as possible.
We have already gotten around 54 surveys completed, which is great. So thank you to everybody who has completed the survey.
I just have a question. Is it a formal recommendation from the Bureau that each agency have a pediatric emergency care coordinator?
Not at this point. We're still in the works as to what we are going to advertise, I guess, the role as in terms of who would fill that position, what responsibilities that they would have. So it's still in the very early stages.
Okay.
It is one of the national measures for EMS for Children. I know this was first brought up to the community about 4 or 5 years ago, and then it's kind of fallen off. Julie has done an amazing job as cases have come under the Bureau of EMS and Trauma System, and it's really bringing that group back together and getting everything back on track with the EMS for Children grant. So we anticipate the first meeting was essentially trying to create bylaws when you didn't have any members to vote on bylaws. But we did start that process. We've got membership now, and I think we'll have a great group moving forward. So that is probably the next big project. Thank you. All right, next to discussion and action items. Can I get a motion to discuss, amend, and approve the EMS meeting minutes from September 19th?
Motion.
Thank you. All right, Dr. Meadam and then Rebecca. Everyone wants to take a minute to review the minutes. Any amendments needed to the minutes? All right, I don't see any amendments. All those in favor of approving the minutes as presented?
Aye.
Any opposed? All right, thank you very much. The meeting minutes are approved. Next up is we need a motion to discuss, amend, and approve updates to the treatment refer program application and manual in the packet.
Motion.
Thank you, Dr. Meadam, again.
Second.
Thank you very much. Melanie? So I will give a little bit of background on this process. The Bureau has received feedback since Treat and Refer initially went live, kind of asking for a review and update to the program. We brought together several stakeholder meetings over the last several months, looking at this program, kind of barriers to implementation, what things could be done to kind of improve and change this to get more agencies to participate in Treat and Refer. We are very fortunate in that we have some agencies that have been doing this for a number of years, and they can really give us a lot of historical data. And one of the things that we recognized when Arizona first put together this program, this was so novel across the United States. We were the first ones that we put together a lot of work, and there was, I think, kind of a white paper in a sense of Treat and Refer. And we recognize that is something that we still want to have in the background as kind of a historical reference as to how we got to Treat and Refer in Arizona. That in 10 years, if someone wants to know why are we doing Treat and Refer and how do we get there, that will still be there. What we did recognize is that the current program was really, the feedback we got from stakeholders across Arizona was that it was just not something they could implement with the current practices in place. So we brought together stakeholders from all across the state, lots of different jurisdictions, different types of entities to get feedback of how we could improve the process. So in your packet, and I think this did go out ahead of time as well, we've got the new manual for Treat and Refer for approval, as well as an updated application for this as well. I'll kind of briefly go through the actual application. So we give a very brief introduction about the background of Treat and Refer. Recognizing now we've had this for several years, we will still have the historical reference available on the Bureau website, but we don't necessarily need pages and pages to explain the process. We've been doing this for quite some time. The EMCT educational requirements, this was probably the point of most discussion over the years. And really one of the things that we recognized is a lot of agencies, when they looked at Treat and Refer, weren't going to necessarily implement treat refer for all different diagnostic entities. And so to require education on neonatal disease when essentially it's an exclusion to treat refer did not make sense to a lot of agencies. And so we looked at treat and refer and said, okay, what are the things per the initial mandate was really to have a behavioral health component. So we felt that 1 hour on management of behavioral health from a treat and refer perspective, and then also 1 hour on education of the concepts of treat and refer. So what does treat and refer actually mean? What are different types of facilities? I think that's probably the key piece of information that EMS doesn't necessarily know. They know how to take care of diabetes, but they may not know necessarily what a doctor's office, urgent care, freestanding ED, or emergency department can take care of. So that's probably the focus of education. So we really decided that there would be a minimum of 2 hours of training to cover those topics, and any additional training would really be determined by the agency and what treat and refer guidelines would be implemented. So if your agency is going to implement 10 different treat and refer guidelines, you would probably need significant more training hours than an agency that's implementing only a behavioral health treat and refer guideline. So that is a little bit of background on how we got to the training requirements. For ongoing training, we recommended a minimum of 1 hour annual ongoing training. Again, with the thought that anytime you implement something that's different from how people were initially trained, you want to do a refresher. This speaks to what Dr. Space talked about with EPIC. You get that kind of fall off from what people were initially trained on. So again, just reminding people, and the way we treat patients in medicine is changing. So what an ED sees now versus urgent care, there's a lot more crossover. So I think an annual reminder of those things is important. There was some verbiage in there with requirements for administrative medical director and educational requirements. This is not something the Bureau could really ever enforce. Essentially, if you meet statutes to be an administrative medical director for EMS, that should be sufficient. So the other kind of suggested requirements, the group voted to eliminate that. Standing order and protocol guidelines. So historically, the Bureau had kind of a repository on the website of multiple different agencies and regional treat refer guidelines. We committed to putting together a draft TTTG format, kind of updating those that are optional for agencies' medical directors to use. So we wanted to say for an agency that's potentially smaller, they're using a medical director out of a base hospital that may not be getting reimbursed for this work, that the agency could download those guidelines, and if their medical director approves them, they wouldn't necessarily have to recreate the wheel and make their own guidelines. We have requested that an agency either let us know which of those guidelines they would use, or if they're not going to use those, just provide us a copy of their guidelines. Part of that is we just want to be able to track what is being done in regards to treat and refer across Arizona. So I think by requesting that we get a copy of that, it's really more of a way of us being able to track. We have 20 agencies doing behavioral health. We have 2 agencies doing diabetes, treat and refer, and kind of looking to see that data collection. For performance monitoring and improvement plan, we basically stated that all agencies shall have a continuous quality improvement plan for treat and refer, and to provide a copy of this to ADHS. Again, with the mindset is, if you have to actually give us a copy of your CQI plan, that means if you've taken the time to write it. So that's, it's not really something that we can actually tell you how to do something, but if we have to get a copy, that means you spent some time putting it together, you've reviewed it, and you provide us a copy. So we felt like that was a more realistic and probably a more beneficial way of actually making sure that CQI is being done on this. There was quite a bit of data from Chandler Fire, who's been doing CQI probably the longest of an agency in Arizona. They've done this for the longest period of time. They have a lot of data, and really their safety data that they've found on this is pretty reassuring on the program. The next piece on data collection and submission, this was pretty simple. In order to do treat and refer, you have to submit data to AZ Peers and an AZ Peers compliant format. We simplified the verbiage to that. One of the big barriers that we found out was that there was some difficulty in kind of meeting the treat and refer specific data elements. And so really we said, let's just kind of make sure that we're getting data that's compliant with the AZ Peers reported. So it's a much more simple description of that data. We also said that we would like an agency, if they have any change in vendor or there's a gap in data submission, to notify us. So if for some reason you change vendor or you have some type of big IT glitch and the data is not coming across, just to notify us so that we're aware that you are aware that the data is not coming, and we will work with you to make sure that that can get reestablished. Follow-up was a big piece of the initial treat and refer program, and one of the things that we recognized is that this is incredibly difficult. Follow-up from an emergency department standpoint is really hard to pull off, much less from a treat and refer pre-hospital standpoint. And so this is now going to be an optional process. So there's ways that people could do this. So linking with the HIE, an agency can enroll in the HIE, but it is a manual process. So there is a way to do this with our HIE linkage program. And so, again, another plug for all the work that's been done linking AZ peers to HIE. But that was now made optional. Patient satisfaction, the feedback from agencies who have done treat and refer is that they get incredibly positive feedback from patients. They do not get any negative feedback about this process because patients often don't know where to go to seek medical care. And if you can give them other options of where to seek medical care, they're very happy with that process. So we listed this as an optional thing. In the emergency department, I will say patient satisfaction survey results generally hover return rates like 1% to 3%. It's incredibly hard to get people to do satisfaction surveys. And so really trying to get the EMS agency, especially a smaller rural agency, to develop a patient satisfaction tool that's reliable would be very difficult. So that is an optional. If an agency wants to do it, they certainly can, but would not be a mandated part. The application for the program must be complete with all the required supporting material. The initial recognition is 3 years of service. And loss of status, it specifically says the loss of recognition does not disqualify an agency from applying again in the future. And some examples of where you may lose loss of status, so if you stop submitting data and you don't tell us or you have no intention of resubmitting data to AZ peers, that's probably the biggest reason. Again, that falls back to your data submission requirement. And then if for some reason Access revokes your treat and refer recognition status, we feel like if Access is saying you can't do this because you were doing something weird with billing, then we probably shouldn't let you do it either. So those are just some of the examples. The application is attached as well. We've also simplified this significantly. Part of the reason is we recognize that different agencies have different sizes, and so some of these people may fulfill multiple entities. But we really felt the key thing was your administrative medical director. If you have an administrative medical director that's overseeing this, some of the other requirements that were included weren't necessarily needed. And a lot of the data we have through other data sets. So that is 3 work groups summarized in about 10 minutes. So we are open to any questions, comments, or feedback.
Yeah, I have a couple. First of all, I'd like to commend of all the great work with this. I'd also like to make the motion for approval of this, if that's what you need. I believe you do. And I also want to make sure that I understand that with the change in the educational format, you are clearly addressing the issue that a person doesn't have to swallow the whole apple, that they can decide what it is. And so it might be beneficial to make that statement earlier in the layout of it, is so that that's clear, so you don't have to look in the weeds for that answer, because there's a perception out there that it would be nice to just clear up right now, is to say that, you can decide what particular part of treat and refer you can do. And so that would be my recommendation, but I do make the motion for approval. And thank you, Rebecca, for all your hard work, really.
I'd like to echo Mr. Ramsey about the accommodations that you personally and the Bureau need regarding this. This is a great effort to kind of reduce the impediments to the program for offering treat and refer activities, because obviously we want more programs to step forward and do this. One of the things that historically I think was a part of treat and refer is that if you were going to do treat and refer activities at all, you had to have a guideline that explained how you dealt with behavioral health patients. Is that so? In other words, if you're going to do treat and refer activities at all, you needed to do them for the behavioral health population.
Yeah, can I interrupt? That was an absolute requirement by Access.
Okay, so that still stands, correct? If you have a treat and refer program, you need to address behavioral health population. And kind of the corollary to that is you can run a treat and refer program and only address behavioral health. Okay.
And that's why the minimum requirements were essentially behavioral health requirement and just education on treat and refer.
Okay,
Yep, great
just
point.
wanted to clarify that. Thank you.
Echoing both Bob and Dr. Gamber's comments, I think the magical word is barrier to entry. I think by going through this process, you've created a barrier to entry. This is going to be much more palatable. So you mentioned the Chandler, because they were obviously, with Chief Wiggins and their leadership, very instrumental in the beginning. How many agencies today, other than the city of Chandler, are currently approved for treat and refer in the state of Arizona?
6.
How many of those 6 are currently receiving reimbursement from Access?
1.
Yeah. I would call that a failure. It's unfortunate that it's been that bad since the start of the program. And I think this is a fantastic step to kind of change the course, if you will. I'm curious, though, and I don't know much about what's going on with this, and if the committee can readdress and look at the comparison now that we have this whole new ET3 kind of beast that's out there from the federal government on how ET3, in comparison to our treat and refer program in Arizona, where there may be similarities and we might be able to, lack of a better word, piggyback on things that are going on. Because you can see if you read the purpose behind ET3, Chief Camelli and Mesa is like right in the middle of that. And it just sounds so much like if we were to work in concert in some way from a state perspective, we could. Sounds like we already doing that. Sorry.
So I'll just briefly address that. I do not speak for Access, but Access was present in the group meeting, and we got really good feedback, and it sounds like they are very interested in implementing ET3 or ET3-like at the Medicaid level. So we think we will see more of that, and Access has expressed interest in that.
So I spoke with Dr. Lee, Mark Lee, who's the previous medical director for Access. He didn't know what the word ET3 meant.
Unfortunately. Can I make a comment? And you know, James or Jimmy, I understand exactly what you're saying about reimbursement, but I will tell you from my experience and understanding, which I think is both historical and deep, and I've been involved in the system, I don't think it is a failure. I'll tell you why. Because the reimbursement part of Access is not a byproduct or an outcome because of the system. It is an outcome because the agencies use billing systems that don't even know how to bill for the treat and refer. So the blame of not getting the reimbursement is probably not in the system as much as it is in the agency that they're utilizing to bill for the Access piece. And so I clearly will tell you that's exactly where the blame lies. And so the ability to straighten out your billing systems to be able to bill properly to Access will get you the funding that you need.
So there's one other component with treat and refer that has consistently been raised across cities that are already recognized, and that's city council willingness to bill. There is still very much a misperception around what treat and refer is, what the billing mechanisms are, who will be billed for them, for city council to actually approve pursuing billing in that situation. That is definitely a piece that's really, really critical for conversations as awareness raises, as more and more agencies come on board with treat and refer. That will definitely help in that momentum. I do know Surprise is only receiving reimbursement for about a third of the billing that they have going forward, and they are using a well-respected billing company to do that billing and still only receiving about a third of this reimbursement.
Great example. My mom's a council member in Surprise, and they are very happy with the program and
They've
very
been
pleased.
incredibly progressive.
Yeah.
It's been great to work with them.
Well done.
They've been great.
So we have a motion to approve. Is there a second to that motion? All right, thank you very much. All right, any further discussion? All of those in favor of approving the treat and refer program manual and application as presented, say aye.
Aye.
Any opposed? Excellent. Thank you very much, everyone. And thank you again to the work group. That was a lot of effort put into developing this. So big thank you. Next, we are going to discuss the Cactus Data Completion Report. In your packet, there's kind of a summary letter that we put together. And SR, just to give a little bit of background to this information. So One of the things at the September 2019 EMS Council meeting, they had requested that TEPI set a threshold for data completeness for an agency to maintain PEEP status. In November 2019, TEPI reviewed the CACT data set as it was written at that time and felt that we needed to do a little bit more deep dive into the data before they made a data completion recommendation. So with that in mind, we sat down and literally went line through the CACT data set to figure out where some of the issues were that needs to be reworded and recoded to make sure that we had accurate data. The feeling from TEPI was that if they were going to make a recommendation for a data completion standard, we wanted to make that recommendation on data that was good data. So essentially that was kind of problem number one. We knew there were some issues with the data. We wanted to clean up the data set, and so that was kind of the first bottleneck that we needed to address. So we went through line by line and addressed any of the outliers to fix some of that data piece, and then started the process of rewriting the data. Vatsal can speak to this a bit better, but literally when she would run the CACT report, it would shut her computer down for 3 days, and then she could do nothing else on her computer for 3 days. And so we actually had to do a lot of outsourcing for things that are well outside of my IT knowledge to get something that was function. That took it, I think, from a 3-day run to
1 day then.
A 1-day run, so significant change. So we've kind of, as we've gone through this process, since this is really kind of a new program, we appreciate the patience of this group, but we wanted to make sure if we were going to make any recommendation or vote on something, that we do it with the right information in place. So first, we needed to fix the data, make sure it was good data. Then the next step was to rerun the report, which was done. So that was kind of the initial plan. Once we had the new report, we then needed to figure out a timeline to go back to what EMS Council's request was initially. And that was what took us to, okay, we ran the report in December. This month, the reports were updated to the agency portal, and then we were going to present kind of the new updated report today. The next proposed that we would just like support is not a voting item, but we just are hoping for support from this group, is that EMSRA, which is the EMS Data User Group Committee. That's really like the data people from each EMS agency. These are the people that know the ins and outs of the EPCR and how data kind of maps across the state system. That they look at this report, they make their recommendations to TEPI. TEPI will review it the EMSRA meets in February. TEPI will review it and make a recommendation for a completion standard in March. And then in May, that recommendation would come to EMS Council to vote on, and that vote would be essentially developing a data completeness standard to maintain PEEP status. So that's a lot of background of kind of why we slowed this process down. We really felt like we did not want to make any vote on a recommendation until we knew that we had good data. So that's a little bit of background of how we got to where we are. That's kind of the first page of your packet. When you go through the core data elements, we can, if you look at the core data elements, these are the fields that are documented on every EPCR essentially. What you will see on page 1, we are at 99 to 100% on all data elements with one outlier, and that is line 19, which is patient race. And we recognize that EMS is not routinely going to document this. We understand that, and we're okay with that being a little bit lower. I was actually surprised it was as high as it was. So if you look at the page 1 of core data elements, we're doing extremely well across the state with that. On page 2, again, data elements, most of these are very high. There's a couple outliers. If you look at line 49, response to procedure, and airway device placement confirmation, and end-tidal CO2. These are some elements where we start to see a little bit lower numbers. I can tell you anecdotally, looking at run sheets and speaking to a lot of hospitals and medical directors, that end-tidal CO2 is a tool that's used by EMS a lot, but oftentimes they're documenting that in their narrative. So we know the information is there, but if it's in the narrative, we can't query that or run a report on this. So this is really an opportunity where we say our numbers are lower, how can we get that education out to EMS on the importance of end-tidal CO2 monitoring, and also the importance of documenting it in an area that we can actually run a report on. So some of these variables where we start seeing a little bit lower numbers, I think that's actually a great starting point of where we can do education and training. When we go into trauma data elements on page 5, I believe, this is where you start seeing some highly variable numbers. And this is something For me, I didn't really understand, because if you look at line 17, trauma center criteria, this is always an EPCR report. Medics and EMTs can always get information, but it's in the narrative for the most part. The reason they went to a trauma center is in the narrative. The part that's important for EMS to understand is that the trauma centers, when they report the data to the National Trauma Data Bank, the National Trauma Data Bank requires them to get that data specifically from a drop-down field. They cannot look at the narrative. So while that number is really low here, this is again an opportunity for EMS to say, hey, we need to educate our crews on why we need them to use those drop-down fields when they're doing their EPCR and trauma patients.
Doctor, I'm so glad that you brought that out, because what we have to be very fearful of, and and so that we're not in the world of with that beautiful statement of the Tower of Babel, is that to understand that the information and the percentages at the bottom are not reflective of the system, because the data might be there but not in the spot to produce this report. So it's very, very important that we always understand that the bottom line of these reports may not be correct, because the data may be present and there's no evaluation of whether the data was there but didn't get transmitted in the piece, which then can give you a distorted view of whatever it is. So it's very important that the educational system is that we keep moving a pursuit of being able to get the data in the data slot, so that the report will be able to be reflective of the reality of the situation. Because in most cases in the world, we don't measure what we do what we measure. So we have to be very careful of the consequences of that piece. So that's why I was very leery about, as those percentages of information in trauma, you get that smaller and smaller percentage. It doesn't mean that those people haven't complied, it's just that the data maybe in the narrative or somewhere else. So I just think that in the report, it should always be reflective of that issue, and how can we measure, I don't know how to do it, but how do you measure the quality of whether the data is there but it hasn't gotten into the report? Is it getting better? Is it improving and all that? And that's a great challenge here.
Anecdotally, once I've educated crews on why we need them to put in that area and where to find it, it's something that it's actually easier than them typing it out. It's clicking on something, so it's easier for them. But I think it's understanding the importance of that piece.
Right.
And so this, to me, I think is a really good opportunity to take some of these low elements and say, focus your education, your documentation education on this, and I think we could very rapidly make a significant improvement.
Right.
So again, if you look at kind of each of the next few, so if you look at stroke, one of the parts that I noticed was lowest here, and again, it's something that is done all the time, but I think it's making sure that's clicked, is that a pre-arrival destination alert is done. So EMS is excellent about doing a stroke alert to the hospital. I know they do them all the time, but again, this is an opportunity to do that education of clicking that button in your EPCR to get the date and time stamp of when you actually did that stroke alert is vital information. And so these are the pieces that we can then, I think, give feedback and look at how to guide the training in that piece. STEMI, again, the activation alert is probably the lowest one on this. One of the things that we saw that I've done some training on internally is when you see aspirin, a lot of times patients took their own aspirin, or if they're at a doctor's office or urgent care who called 911, that facility gave them aspirin, is doing the education of put that aspirin into your treatment field as prior to arrival. Now it's showing documentation that you thought about aspirin, which is critical to outcomes for these patients, but it's putting it in a field that we can actually measure. So again, this is using some of this knowledge to help guide our training and education. And then the cardiac arrest, this is, again, one of those things where this is a little longer report, and some of this, because a lot of these elements are share elements, and the share elements are required fields. We actually do pretty well at a lot of these elements. You'll see destination alert is very low for cardiac arrest. I would venture to guess there's not one code that's transported without some type of alert done to the hospital. So again, just an opportunity to do that education. Brian, I'm sorry, did you have a question?
I'll wait until you're done. I have actually just a couple of questions, so I better understand how a couple of things are working in here.
The opioid data elements, I will just say that these are designed in statute. These aren't necessarily the clinically relevant data elements, but these are in statute, so these are what we collect. So that is kind of the piece with the opioid reporting as required. So this is kind of a little bit of background. Again, this is not an action item for today. We're just hoping for support kind of with the process, with the timeline of this moving forward, with it potentially being a vote to the May 2020 meeting. One thing that I know Ben has really wanted to say, there's been questions raised over the last year, is there a difference between vendor? And the answer is no. In all vendors across Arizona, there's agencies that have a very high completion standard and agencies that have a lower completion standard using the same vendor. So what we've recognized is that, that was one of the concerns that was raised initially, and I think Ben, let me know if I did not explain that well enough, but I think overall we can very reliably say this is vendor agnostic.
And, sorry, Brian, I'll just real quickly thank you all for your patience on this. I know this has been a long time coming. We had a pretty significant technical limitation over the winter that resulted in a delay, and we're still trying to honor the process we described where it would go from MSRUG to deputy EMS counsel, and so we know that slowed things down even more. So, we want to be kind of slow and deliberate here, because the worst thing we could do is rapidly roll out something that's wrong, that frustrates everyone. And so we just thank you for your patience with all of this.
So just a couple of questions, so I get maybe in my brain how some of this is right at. So I'll use the stroke one on pre-arrival alert or activation. So I have many areas in northern Arizona where the hospital or facility they're taking a patient to is not necessarily stroke ready, or a primary stroke center, or any of those kinds of things. They don't have any activation method. So if that's not marked because they don't do it, that shows up in here then, right? And there's no way to compare anybody who has a stroke alert in their system and they're not doing it versus those that just don't have it, period.
So do you want to talk about acceptable null
No, I
values?
think the response to that particular variable is just yes and no. So there is no way we can capture that information.
So it's, yes, it's for the stroke arrival one, it would be the stroke. You're saying, what kind of activation are you doing for your
No,
time in the
many
stroke?
places won't have an activation. They don't have that in their system.
Right.
So,
Or trauma, or
so
whatever.
then that gets, if it's a no answer, is that still no versus a no answer?
No, so basically you choose the category stroke as your arrival activation. And if you don't choose stroke, and even though the primary impression says stroke, then that means that's not counted then, right? So my primary impression is stroke, but the activation arrival, one of the response is stroke, and if we don't choose that as a response, then it comes as a negative over here.
So just to clarify that a little bit, so we're literally looking for blank stuff. So in all these fields, there's a not applicable, not available, in all the drop downs, there are reasons why you may not have done this item, whatever it is, stroke alert, something like that. We're literally looking to see if nothing, like the drop down, never selected, never transmitted, So
But any other response on the drop down is
you're golden. Yep, you get credit for it.
Okay, and then one other example is on STEMI, oxygen administration. So the AHA, if the person's SpO2 is greater than 94%, they don't necessarily recommend oxygen administration. So is that still a drop down that you would just choose yes or no, and that's just a no answer?
I'll let them know. So what happened is that if you see STEMI patients, we have, and if you see 1,676, right? But in medication given, the number of incidents is not 1,676 because not everybody needs oxygen. As you say, might have greater than 94%. So that's why my denominator decreases. It's only 1,385 patients where I'm looking for that you should have some documentation of oxygen because oxygen saturation is less than. Yeah, exactly.
So that's one of the things that we spent a long time working with Dr. Bradley about was There is some conditional logic in here to try and weed out documentation where we don't think it's necessary. So that's a good example is if you've documented an SpO2 in the field of 94 or greater, we don't expect you to have applied oxygen.
Okay.
So the good way to look at it is that if we see the N in that red line, like for example, STEMI N is 1,676, and then if you see that N changes in the column number of incidents, then you know that, okay, the denominator has decreased. That is because we have applied some logic because not each and every patient qualifies. And then if you want to know about that logic, I mean, we are happy to provide you that logic, or there is some guidance. Already we have created a document which talks about those things.
Okay, so for example, in the oxygen, there were 1,385 people who should have been put on oxygen.
We are talking about now
On STEMI.
STEMI.
Back on the oxygen on STEMI.
Right.
And only 54.3% of those got it.
Exactly.
Okay.
Documented.
Yeah, I'll nitpick that more. Yeah, we're not even getting into performance improvement.
That's a pretty easy one that I would expect most people to have in their treatment section, but maybe not.
Again, that is one of those things that I see a lot in their narrative that aren't necessarily in the treatment. So again, opportunity, to me, I think this is really an opportunity to kind of say, moving forward, this is, you know, if EMS Council makes a recommendation on data completion standard at the next meeting, then that would be the standard. So it gives agencies a lot of time to do training, to educate on these specific things and the importance of documenting those elements.
This is a perfect example of the iterative nature of EMS data improvement. And one of the things that we have found that's really good is all emergency care providers, from first responders to board-certified EMS physicians, are competitive. And one of the things that we have found is whenever we actually start giving when the feedback gets back to the provider, and they are then able to say, well, wait a second, I documented that, and then someone can say, well, that's true, but in these areas, you got to do drop-downs in addition to your narrative. What's interesting is how easily that happens without reprimand or anything else, just by getting the data back. And so I would really encourage everybody at every level to become iterative and to actually make the data available. Because nobody wants to be 50% at anyone in our specialty, at anything in our specialty. And what's great is, literally, it self-corrects. We have seen that in share dramatically over the years in the agencies that were really focused on getting back to the provider. So if this stays at the administrative level, I would not expect the needle to move much. But if there's a way to get agency-specific stuff back, and it's really remarkable how much better it can get.
And just a reminder, we're going to run out of time pretty quickly here. So reminder that the agency-specific reports went out to all agencies on Sunday, so those have all been distributed. If you're having any technical issues getting into that, please contact Ann. One of the things that we know is that because this is agency-specific data, we keep it highly protected. So if you have different AZDHS usernames or logins, there is one specific for this report. So that has been one of the barriers we've discovered. So any issues accessing that, please contact Ann. She's already gotten several agencies who were having some trouble to work through that. So any further discussion on Cactus? All right, again, not an action item, but we just wanted to make sure that the group felt comfortable with this time frame moving forward. So
I just want to say, this is great work, really great work. I don't know that anybody else has taken this on. Big deal.
thanks. Any agenda items to be considered for the next meeting? Call to the public? Yes.
So I want to thank formally Terry. Our EMS Helps breakfast is on February 11th. You're coming up pretty soon, and I wanted to thank the Bureau for agreeing to publicize it on their website. If you've not heard about the breakfast coming up on February 11th, if you go to emshealth.org, Dr. Rob Brewster from Peoria Fire will be speaking on resilience. It's a free breakfast to attend at the University Club in downtown Phoenix. Again, emshealth.org. And also I'm very pleased to announce that both Dr. Bradley and Dr. Dara Ramsey are two new board members at emshelp.org. And the last thing I want to make a note on is a photo I'm going to show, is that 1 month ago today, I got this photo sent to me. So Roy Riles, those of you who know in the room, 1 month ago today coded twice and was defibrillated. And he's sitting in the room, and all too often we hear about these stories of our friends that it happens, and we'd be talking about it today if he wasn't here. The fact that he is here, I'm very glad you are here, Roy, and thank you for being a 30-year friend.
ACLS works.
Summary of current events are in your packet. Next meeting is on May 21st at 10:30 a.m. Can I get a motion to adjourn?
So,
All right, thank you, everyone.
Yeah, I think there's